Okay, so we're tailing pneumonia on after secondary BSI presentations. In the past, we've always talked about this in conjunction with VAE, but this year we've pulled it out to talk about it specifically, and we decided the nice place to slide this in is with following the secondary BSI attribution period, because that is the most common, at least from our perspective, what we see use of the pneumonia definition. As Dr. Cardo and Dr. Pollack mentioned, pneumonia is an HAI that occurs quite frequently, and we do see that in our EIP prevalence studies. So when you're doing your CLABSI surveillance, you quite often are probably looking to see if you can attribute that BSI to a pneumonia. So with that, let's get going here. So what we're going to do today is just do a quick review of what is available as a lower respiratory tract event. I'm going to cover some pearls of wisdom, if you will. We'll review imaging test evidence, because that's the tricky part of the pneumonia definition. And then, as I said, we'll circle around and talk about pneumonia as it is used for a secondary BSI assignment. And then at the tail end, we have a couple updates to the protocol in 2019. So we have 4 lower respiratory tract events within the NHSN Patient Safety Manual. Pneumonia, LRI, lower respiratory infection, and lung is the specific infection, VAE, and PVAE. So before we go on, I just want to remind you what in-plan and off-plan refers to, which I'm sure you all know, but let's just make sure we're all on the same page. In-plan surveillance is indicating that you have selected that particular event in your monthly reporting plan for the specific location. And you, by doing so, are swearing, cross your heart and hope to die, that you're going to follow the protocol in its entirety, and you're not going to make any mistakes or misidentifications when you're doing that particular surveillance. Just kidding. Not kidding about following the protocol, just the cross your heart. The facility for off-plan surveillance, you can do any of those infections that are in our protocol off-plan by not selecting them in your monthly reporting plan. Maybe it's a state requirement, maybe it's your facility just wants you to follow certain events. So that would be your off-plan. So I talk about that because as we go through and I discuss these lower respiratory tract events that we have, I'm going to point out which you can do in plan and off plan and where. So with pneumonia, the only location where you are able to do in-plan pneumonia surveillance is in a pediatric location, and that is on ventilated patients, and we refer to that as PEDVAP. It is still an event that's available, like Latasha reminded you, just like UTI, just like all the events that are in Chapter 17, for secondary BSI assignment or for just off-plan surveillance in any location, any age patient, whether the patient's ventilated or not ventilated. For LRI lung, it's very similar to that. You can use LRI lung as a site for secondary BSI assignment, or if your facility or your state requires you, or another reporting entity requires you to do lung surveillance, you can certainly do that. It's just that you cannot select that event in your monthly reporting plan. You can do the surveillance, you can report it into NHSN. We will just not be using that reported information when we aggregate the data and provide benchmarking, and of course it's not sent off to CMS. Now VAE, that is available for only ventilated patients in adult locations, and that's the only place that you can select the event as an in-plan event in your monthly reporting plan. With VAE, you do have the ability to attribute a BSI as secondary, but you must progress to the third tier of the VAE algorithm, PVAP. PVAE, a new event this year, is available for ventilated patients in pediatric and NICU locations. Now, this is a single tier, and we're going to talk about both of these events later. We'll have separate presentations, but just want to cover them as they late to secondary BSI assignment. For PVAE, you cannot attribute a BSI as secondary to a PVAE event. Okay. Now, if you didn't capture all that, or if I confused you, you can go to the pneumonia FAQ location on the pneumonia website. There is a specific FAQ that deals with what events are available for lower respiratory tract infections and when they can be used, when they can't be used, in plan, off plan, secondary BSI. And there's also a very similar, in fact, it's probably word for word the same FAQ on the VAE and the PVA web pages. As far as using pneumonia as a secondary site ability to attribute a secondary BSI, we have reminders in both the BSI protocol and the pneumonia protocol to keep you clued in that you can still use pneumonia. It's not available for in-plan reporting in adult locations and in NICU locations, but you can still use this event as a way to look to see if the BSI is secondary. Okay, with that being said, we have a question. Get your phones and computers, however you're participating. When can you use the pneumonia definitions? Never. Always use VAE for adults and PVAE for children and neonates. When conducting in-plan surveillance on mechanically ventilated children who are in a pediatric location. When opting to conduct off-plan surveillance in ventilated or non-ventilated patients in any patient location. When determining if a BSI is secondary to a lower respiratory site, or B, C, and D. Okay. Give a little more time here. All right, we'll cut this right off right now. Well, we'll give you a little more time. The web streaming individuals, there's a little bit of delay, so we want to make sure we give them a little bit adequate time to provide a response. And I can't control my mouse here, so where is the mouse? Aha. All right. And the answer is E. Very good. Now we're going to go on a little bit more just to make sure that you remember that by the end. So if you're going to use pneumonia for all of those different purposes, where do you find it? Well, it's not found in Chapter 17. It's found on the acute care, the long-term acute care, inpatient rehab, and the inpatient psych facility pages, as shown here. You can click on that. It'll take you to a location that looks like this, regardless of what the facility type is. We have the protocol section. Click on that. Click on the link, and voila, you're into the pneumonia protocol. Within the pneumonia protocol, pneumonia is the major type of infection, and there are 3 algorithms within the pneumonia protocol, NEU 1, NEU 2, and NEU 3. NEU 1 has 3 different algorithms, one for any patient, one that is specific for infants less than or equal to 1 year of age, and one that is specific for children greater than 1 year and up to less than or equal to 12 years of age. Any patient can, you can use that any patient pneumonia 1 algorithm for any patient. So you aren't just limited to the infant and the child algorithm for those age categories. Now the NEU 2 algorithm, there are 2 of those as well. One that is specific for common bacteria or filamentous fungal pathogens. And then another that covers viral, Legionella, and bacterial pneumonias that have very specific laboratory findings. And then the third specific type infection in the pneumonia protocol is PNEU3. This is limited only to patients who are immunocompromised, and that immunocompromised status is determined by the definition provided in the protocol. So when you're meeting PNEU1, PNEU2, and PNEU3, regardless of which algorithm you're following, you have to make sure you have the imaging requirement met, and that's a good place to start. If you don't have imaging, don't even carry on to see if you have symptoms or laboratory findings. If you can't meet the imaging requirement, unfortunately, you're done. You can't use pneumonia. You must meet the signs and symptoms requirement that are outlined in PNEU 1, 2, and 3, and they do change depending on which algorithm you're looking at. And this is a very important part, and I will stress this as we continue on today. You need to meet the footnote requirements. So I'll point some of those out to you. And then when you're meeting PNEU2 and PNEU3, this is where you'll find the use of a laboratory, a culture result, a non-culture-based testing result that you can use identification of a pathogen to help you meet the pneumonia definition. So, some pearls of wisdom. And these little pearls happen to be found in the protocol. So, when we're done today, if I have confused you or if you want to read a little bit more about the pearls, rush back to your hotel and whip out your protocol. So as I alluded to earlier, although the specific criteria are included for infants and children and for the immunocompromised populations, any patient can meet the other pneumonia criteria. So an immunocompromised patient is not just limited to meeting PNEU3. They can meet PNEU1, they can meet PNEU2. Same with an infant. You can still use PNEU1 for any patient, and you can use PNEU2 or PNEU3. There is a hierarchy if you are reporting into NHSN, where you report at the highest level met or the highest number. It's not necessarily that one is worse than the other. It's just that if you meet PNEU1 and PNEU2, report it as a 2. If you meet PNEU1, PNEU2, PNEU3, report it as a PNEU3, and so on. Pearls of wisdom number 2, pathogens and secondary bloodstream infections can only be reported for PNEU2 and PNEU3. You cannot report a bloodstream infection as secondary to PNEU1. There is not, 1, a site-specific specimen included in meeting PNEU1 algorithm, or 2, there is not a blood specimen. So since Latasha's spent a wonderful time with you talking about how you meet a secondary BSI without that site-specific or without a blood culture, you're unable to attribute a BSI as secondary. And in fact, if you enter a pneumonia into the NHSN algorithm, the secondary BSI assignment field defaults to no, and you can't change it. So here's our Pearl of Wisdom 3. Don't forget the footnotes. There's a lot of really important information. Those little numbers that are highlighted here on the screen give lots of very pertinent, very important information. And if you don't take the time to read those, you may be, 1, either missing meeting a definition, or 2, meeting a definition in error. So these footnotes follow the algorithms in the protocol. Okay, now this is a little quickie knowledge check. I did note in your reference manual, if you look at day 5, the new algorithms are in there and the footnotes. So if you want to work through this particular knowledge check, you can refer to those algorithms. We have the checklists actually in your reference book. So we have a definitive imaging and test evidence. So just take my word for it. The imaging is met. The patient has a fever of 38.9. There is documentation of new onset cough Rails, and the Pseudomonas aeruginosa has been identified in an expectorated sputum specimen. All of the above have a date associated with them such that they're all falling within a 7-day infection window period. What is identified? New 1, new 2, nothing, I don't know. And I'll hope that I don't see any I don't know answers. Don't succumb to peer pressure. Don't make your answer and then change it and go back and forth. What is the trick to get this mouse over here? All right, I'm just going to hold it right there. It's just, yeah, okay, that's what, all right. All right. That's not what I wanted. There we go. Okay. The answer is new 1. Why is that? Because sputum is not a minimally contaminated specimen. You cannot use that to meet new 2, and guess where you would find that out? In the footnotes. We have a footnote, number 9, which tells you that sputum, if it's an expectorated sputum or it's a tracheal secretions, it's not being collected from a protected airway, an ET, or a tracheostomy, that the specimen is not eligible. So you cannot meet new 2 with that sputum specimen. What if we change the specimen to a BAL? Same scenario, same symptoms, same organism. It's just that now you have Pseudomonas coming from a BAL. Can new 2 be met in this scenario?
The results are hidden. That's okay. Just click that so we can see them come through.
Oh. How did I do that?
You must have did it before. Previously.
Okay. Sorry. Now you can, I think I liked it better with the results hidden, then we don't have peer pressure getting you to change the answer. Okay, so the answer is maybe. You do have an eligible specimen. It's a BAL, but you need to know the quantity. We don't have the quantity of the Pseudomonas. And again, guess where you find this? In the footnotes. You have to check for table 5. You need to know if you have an acceptable quantity that can be used to meet new 2, even with the BAL specimen. And if your laboratory doesn't happen to report out these specimen types using colony counts, you'll see the little note below, and this is actually the same, we use the same little transition or comparison in VAE. If the specimen is reported with a semi-quantitative result of moderate, heavy growth, many, 2+, 3+, 4+, depending on how your lab quantitates, that will make the specimen eligible for use. Okay. All right, now let's talk about the favorite part of pneumonia, imaging test evidence, or not the favorite part of pneumonia. It is challenging. It's what makes this definition difficult. It's what made this definition be removed from use in the NICU location back in 2014. The findings must be new and persistent or progressive and persistent. So unlike our other definitions where we have imaging test evidence used, you don't have that persistent requirement, but you do when you're conducting pneumonia surveillance. You simply finding the words that are listed in the protocol, infiltrate, consolidation, opacity, airspace disease, is not enough. You can't just do a word search and find a report, a radiology report that notates one of these. You need to make sure that it's persistent. You need to make sure that the notation is saying that it is representative of pneumonia. And again, as I said, unlike the other definitions, you have to have persistence. And you can only use definitive or equivocal findings. And for purposes of pneumonia surveillance, atelectasis is not evidence of pneumonia for use in meeting imaging the requirement for pneumonia. So let's talk a little bit about this. So we need evidence that's suggestive of pneumonia. You need new or worsening finding of infiltrate, consolidation, cavitation, pneumatoceles if the patient's less than or equal to 1 year of age, or other descriptive words that we consider to be useful, for example, opacity, airspace disease, density, and in the report, they cannot be attributed to something other than pneumonia. That's a catching point. And then, if you have more than one imaging test, and in some cases you're required to have more than one imaging test with the evidence of pneumonia, there has to be evidence of persistence. There can't be rapid resolution. A pneumonia does not resolve rapidly on imaging. Whatever was reported with using one of those little keywords was probably not representative of pneumonia. And you can't have a subsequent finding which now is saying, the opacity is probably related to pulmonary edema, or, there was a report of opacity, no qualifier of what it was representing, but now 2 days later they're saying, yeah, we're still seeing this opacity, this is likely pulmonary edema. It's no longer eligible for use for meeting the imaging test evidence for pneumonia. What if the findings are equivocal? So when we say equivocal, it's not positive, it's not negative, it's back in, it may be this, it may be that, it may be iffy. For example, infiltrate versus atelectasis. Opacity may be pneumonia, or it may be congestive heart failure. I mean, you can't fault the radiologist. They don't have the patient next to them when they're reading the report. They're giving the report as what they think it could or couldn't be. And it's up to the clinician who's dealing with the patient to correlate that result. So for you, you're looking in the medical record, you find this kind of a report. We would call that equivocal. You're going to look for further imaging test evidence that clarifies the equivocal finding. You're going to verify that the finding is suggestive of pneumonia and that there is persistence, and that will make that equivocal finding available for use. Or if it verifies that the finding is not suggestive of pneumonia, then you're done. You don't have imaging test evidence of pneumonia. What happens if it just continues to be equivocal? Well, in that case, in the absence of verification of whether you can use it or you can't use it, then and only then will you use clinical correlation. And that would be the physician saying, all right, it's clear as mud. We don't know if it's is or isn't, but my interpretation based on this patient's clinical presentation is this is evidence of pneumonia, and he doesn't have to say this is evidence of pneumonia, by the way. He is saying I'm treating this patient for pneumonia, and there's antibiotics specifically designated for pneumonia. Then you can use that. That's the only time you can use physician diagnosis and treatment for pneumonia, because that diagnosis and treatment is not an element of the pneumonia definition. You're using it to support an equivocal finding. Okay, knowledge check number 4. The imaging requirement for pneumonia is met with the following imaging test results. On the 16th, and this, by the way, came directly from a question from a user. The 16th, airspace opacity overlying the heart, more likely to be atelectasis than pneumonia. 17th, another imaging test, persistent dense left lower lobe atelectasis and or infiltrate and small effusion. The 18th, improving left lung base opacity and left diffusion. And then on the 19th, lower lobe opacities have improved, no infiltrates. What do you think? Is there imaging test evidence to meet pneumonia? So the answer is it is false. That first imaging test was equivocal. The second one was equivocal. By the third day, there's results of improving opacity. And in fact, that's the only thing we had that is a keyword that you'd even be able to pull out. You've already got some improvement. And then on the fourth day, they're saying they've improved. And now they're specifically saying there's no infiltrates. So this would not be imaging test evidence that could be used to meet the pneumonia definition. And guess what? You've got some helpful hints in the footnotes 1, 2, and 14 to help you make decisions on meeting the imaging test evidence. Okay, let's talk a little bit about pathogen exclusions. For pneumonia, all Candida species or yeast not otherwise identified or specified, all coagulase negative staph species, and all Enterococcus species are excluded for use unless they have been identified in a lung tissue or a pleural fluid. Those are two specimens that should be sterile. So if you identify anything out of there, we're not going to preclude you from using it to meet the surveillance definition. We do have an exception. Every rule has an exception, and NHSN likes exceptions. You all like our exceptions sometimes too, sometimes you don't, but the exception for Candida is that if the patient is eligible to meet PNEU 3, and this requires that they meet the immunocompromised definition in the pneumonia protocol, then if they have Candida in their blood and in a respiratory specimen, and this is the only time you can use an expectorated sputum, by the way, and the collection date for those two, the blood and the respiratory specimen, are in the same IWP, then Candida can be used. But that's the only time. There's a lot of if this, if this, if this. So it's not easy to use Candida. And you find this information highlighted in the footnotes. Here's where you find the immunocompromised definition for use when we're doing surveillance for pneumonia, and the footnote that tells you that the blood and the site-specific specimen have to have the same collection date, a collection date within the IWP. Okay, now we're going to get to the meat of the matter here of why we are following secondary BSI presentation and the CLABSI presentation this morning. So pneumonia can be used for a secondary BSI assignment. And to do that, you have to meet the pneumonia definition, and then, of course, you have to meet the secondary BSI, either scenario 1 or scenario 2. You'll see we're going to run through scenario 1, meeting pneumonia, and our little table B1 in the BSI protocol, you see that pneumonia is listed there. You can use it for scenario 1. You have to have at least one organism in the blood specimen that matches an organism identified from a site-specific specimen, so one of our eligible specimens for use in meeting pneumonia, and there has to be at least one matching pathogen. So our eligible specimens are the minimally contaminated specimens, pleural fluid, lung tissue, and sputum that is expectorated, again, is not a minimally contaminated specimen. The organism that you're using must be eligible, and the eligible specimen must have a collection date in the 7-day IWP. And then that requires that the blood culture has a collection date in the SBAT for the pneumonia event. So here's some examples of where in the pneumonia 2 protocol you'll see some of those eligible specimens that you can use to meet. And now we're going to run through a couple examples. This is, again, assume that the imaging is met when I say imaging test infiltrate. We're not going to get into that part. We're going to focus on secondary BSI assignment now. So here we have the pneumonia 2 definition met with a BAL specimen with an eligible quantity in the secondary BSI attribution period for that pneumonia event. We have a blood culture with a matching pathogen to the site-specific specimen, so the blood can be secondary to the pneumonia event. Here we have the same scenario, only this time the BAL has Acinetobacter baumannii and Staph aureus, and then we have a blood culture with the collection date in the SBAP. The blood can be secondary to the PNEU event. Here we have the same scenario. Many Acinetobacter baumannii, PNEU is met. We have a blood culture with Staph aureus. What do you think is going to happen here? Secondary or not? Good. It's not a match. There's not a match to the site-specific specimen with the pathogen in the blood. So the blood in this case cannot be secondary. You would just be reporting the pathogen Acinetobacter baumannii. You take that blood culture, you'd continue on your merry way to see if you can find another site-specific specimen that you can attribute it to as secondary, and if not, then you have a primary BSI, and if it's a primary BSI and there's central line associated, you have a CLABSI that you need to report. So with our excluded pathogens, Candida species and yeast, coagulase negative staph, and Enterococcus, they're excluded as secondary BSI assignment as well. So here we have the same scenario. We're meeting with many Acinetobacter baumannii, and we have a blood culture that is Acinetobacter baumannii and VRE. The VRE is excluded. You will have a blood secondary to this event, but you have to continue to investigate that blood culture specifically for the VRE. Again, find out if it's able to be attributed as secondary to another site-specific infection, and if not, then you have a primary BSI. Okay. All right, and then the final is just an example of when you can attribute one of the excluded pathogens. Here we're meeting PNEU with lung, and that is eligible to be used because it's a lung tissue. If you have blood in the SBAP following meeting a PNEU with a lung tissue with VRE or any of the other excluded organisms, you are able to call, in that case, the VRE BSI secondary to pneumonia. Okay, now let's go to scenario 2. We do have the ability to use blood as an element when we're meeting pneumonia, 2 and 3. So let's run through a couple scenarios there. Blood collection must be, when you're using it as an element, of course it has to be in the 7-day infection window period, and you're still going to be applying your pathogen exclusions. So here's where we use blood as an element when we're meeting PNEU, and here is the scenario where you can use blood as an element when you're meeting PNEU3. And incidentally, when you're meeting PNEU3, you can also scoop back to any of the PNEU2 laboratory requirements to meet PNEU3. It's just that you're meeting PNEU3. You're calling it PNEU3 because the patient is immunocompromised. So here we have blood used as an element. Again, the old Acinetobacter baumannii. I happen to like that organism. I don't know why. And it is used as an element, so pneumonia 2 is met, and the BSI is secondary to the pneumonia event. Here we have blood with Enterococcus faecalis. We know that Enterococcus is an excluded pathogen unless it's isolated from lung tissue or pleural fluid. So in this scenario, PNEU2 cannot be met, and if you don't have another sign or symptom that's eligible, you also can't meet PNEU1. Okay, here we have Candida in the blood. In this particular instance, the patient does meet the immunocompromised definition. You have Candida in the blood. You have a sputum. Again, this is one of the only times you can use that expectorated sputum. with Candida, matching the blood, Candida albicans. They both are in the 7-day IWP. The patient is immunocompromised, so the Candida can be attributed as a secondary BSI to the pneumonia event. Okay, now let's just take a trip back to yesterday when Kathy covered Chapter 2. And let's look at the specific box outlined here. If you're meeting, you can meet another definition in the RIT, and you can attribute pathogens. So this can be, and Latasha actually covered this, this can be another way that you can attribute a BSI as secondary if you can meet the event using the blood in the RIT. So if you meet NEU1, and now you have a blood that's trailing in, and darn it, I know this is secondary to this pneumonia event, but it's not, I didn't have the collection date when I met NEU1. If you meet NEU1, and then within that RIT of the pneumonia event, you have a blood culture, if you can find all of the elements to meet NEU2 again, using that blood as a specimen, the blood can be attributed as secondary to the pneumonia event. So you just have a NEU1 that you now can meet another criterion of the pneumonia definition, so the NEU2 can be secondary. So let's go back to that example in our scenario 1 where I said, yep, can't meet this. Well, guess what? This is the example where you can. So here you had a NEU2, and now you can meet NEU2 again using the blood as the element. No, the blood didn't match the site-specific specimen, but if you can meet NEU2 using the blood as an element, you can indeed call the blood secondary to the pneumonia event. And that's all for the secondary BSI. The only thing, and we're going to do it, we're going to get you out of here right at noon. The only thing that I want to point out to you in closing is that in 2019 we had 2 protocol clarifications. These were just to help you out. Again, pointing out that pneumonia is available for secondary BSI assignment. And then the second update was we just reorganized some of the information as it pertained to the imaging and added a couple little notes that would help you when you're trying to determine if your imaging test evidence is met. And with that, I'll hang out down here if you have any questions specific to pneumonia.